Right. Okay. Good evening, everyone. Thank you so much for joining JOMA tonight for Grand Rounds on Beyond Anemia, what is patient blood management, featuring Dr. Margit Kaufman. So, JOMA, or the Jewish Orthodox Women's Medical Association, is a dynamic organization of over 700 Jewish Orthodox women in medicine dedicated to professional growth, community service, and advancing healthcare knowledge through education, mentorship, and advocacy. JOMA empowers its members and promotes health and well-being within our community. And our vision is a Jewish community who has easy access to culturally sensitive and relevant health information and can make informed medical decisions. So thank you for joining us as we continue to support and inspire women in medicine. For more health topics, check out our upcoming webinars and tune in weekly to our JOMA podcast. Tonight, we have the privilege of hearing from Dr. Margit Kaufman. Dr. Margit Kaufman is a board-certified anesthesiologist and intensivist specializing in patient blood management. As a medical director of the Institute for Patient Blood Management and Bloodless Medicine at Englewood Health, she leads initiatives to enhance patient outcomes through evidence-based PBM practices. The Institute is the largest and longest-standing program of its kind worldwide, serving patients from all 50 states and over 27 countries. Dr. Kaufman's clinical and research interests focus on optimizing perioperative anemia management and addressing anemia in critical illness. She serves as a senior examiner for the American Board of Anesthesiology and reviews for anesthesia and analgesia, blood, and transfusion. Dr. Kaufman serves on both the Committee for Patient Blood Management and the Committee for Critical Care Practice for the American Society of Anesthesiologists. Recently, Dr. Kaufman developed a mobile and web-based application to improve compliance with blood management protocols and has begun integrating AI-driven solutions to advance clinical practice. So we're really excited to have Dr. Kaufman with us tonight. For those of you who are eligible for CME credit, please make note of the following. In order to obtain your CME credit, make sure to text the code on the screen, 7EMES, to the number listed, or scan the QR code. The code will expire in a day from now, so Wednesday, May 21st at 8 p.m. So make sure that you scan the QR or send the text within the next day. We'll share this slide again at the end of the presentation. We will also be recording this webinar. It'll be posted on our YouTube channel for later watchers. We'll have some time at the end of this presentation for questions, so feel free to message in the chat, the Q&A box, or message me privately. I'm Shula. I'm on the JOMA Grand Rounds Committee, and we're excited to have you here. So without further ado, Dr. Kaufman.
Thank you so much, Shula. Thank you to also Dr. Lando for the amazing process of getting this up and running. It's exciting to have the opportunity to talk to a wider, broader group of physicians and other clinicians as well who are interested in this topic. I'm sure actually most of you took a look at the title and was like, I have no idea what she's talking about. So I'm going to speak to us a little bit about anemia and beyond, and really what is patient blood management. Just so you know, I don't have no financial disclosures, and if you have any to offer me, I'm always interested in hearing about them. And I also will be discussing off-label use of a medication as part of my presentation, and I will point out to you when I do that. So I'm a bit of a history buff, so I just wanted to give you guys a little bit of the background of how did patient blood management come about. So there is a group of religious sect within the world called Jehovah's Witnesses, and they don't accept blood, but they want transfusion. They don't accept blood, but they want good health care. And so a lot of this story of this progress is through the treatment of patients who did not accept blood transfusions, and also the roles of autonomy, patient autonomy, and different things happening in the world. So in around 1960s, Denton Cooley in Texas was the first one to perform a bloodless cardiac surgery. Cardiac surgery still remains one of the largest users of blood products in America. And so there was a movement already to help provide care for patients for whom blood transfusions were an option. Then come to like the 1970s, late 70s, early 80s, and we start to realize in America and in other parts of the world that our blood supply is contaminated, right? And that we have HIV, hepatitis, and people don't want blood transfusions because they are scared about getting these deadly diseases that could affect them for the rest of their lives. And then there start to be these studies that start coming out in the 90s about patients who are being treated for cancer who were getting blood transfusions and they were doing worse. Specifically, there was in the rates of metastatic breast cancer after mastectomies. So the more blood they got, the worse their metastatic disease became. At the same point, there's this movement toward patient autonomy happening, right? Where we got away from doctor knows best, and maybe the patient has a much larger say in what is happening to them and to their body. With that, the leaders of Jehovah's Witnesses, it's called Watchtower organizations, start to go out to different hospitals in the US and say, hey, can you work with us? We want this care, but we just don't want blood. At Englewood Hospital, there were a few physicians who were interested in why were we giving blood? When should we give it? What should we do? What's the risk? What's the benefits? And they thought this was actually kind of an interesting opportunity at that moment. So Arya Shander, who is my mentor, Herb Dardick, one of the vascular surgeons, some amazing hematologists, oncologists, and OBGYNs, started this bloodless medicine program at Englewood. And they started with just case reports and then small case series and poster presentations. And there were a few other hospitals that started to do small level work, but not as large as Englewood. And then it started to pick up, and we started to collect more and more data that what we were doing for these patients was actually really good medicine, and that they are doing better sometimes than our regular patients. And that came to the late 2010s, where the concepts of patient blood management was codified. In 2022, there was finally agreed upon global definition of patient blood management. And actually, just in March of 2025, a World Health Organization released their patient blood management guidance, depending on what socioeconomic country level status and such you have coming from. So it's more of a recent thing, but there is, at least 2 decades worth of information out there. So I teach residents in my ICU, so you like to start with a case normally. So in the pre-op bay, you have a 69-year-old woman. She has known coronary disease. She's telling, you that she has had like 9 months of tiredness, dyspnea and exertion. She can't walk through the supermarket without stopping and leaning on her cart. She really hasn't been to the physician in over a year. She's not really great about taking her medicines, but she's having her elective hip supposedly scheduled done today. And what's the next step? And when I ask this to all my residents right away, they're like, she's not having her surgery done today, right? This woman needs to be worked up for her cardiac disease. She's not taking her medicines. We don't know that she's medically optimized. We can use whatever risk stratification we want, but this lady, it's too high, and we need to figure out what's going on with her and why she's having these anginal equivalent symptoms. So then I present this case. I have a 69-year-old woman. She has a history of moderate anemia, right? She's in that pre-op bay. She's telling you she's been tired for 9 months. She sometimes gets dyspnea and exertion. She can't walk through that supermarket again without stopping and leaning on her cart. She hasn't really been to the doctor in a year, and she's not taking any medicines, and she's supposed to get her total hip today. And what's the appropriate next step? And this is where all of a sudden, people go, oh, I don't know, it's just anemia, it's not a big deal. Why, let her have surgery. The orthopedic surgeon wants to get into the OR. Why are we saying that? That's actually maybe not the right thing to be saying. So I'm going to kind of take a step back, looking at some of the different data that's been coming out. And we'll start with the lower level data and we'll move up. So this is 2009 single-centered study. It was looking at pre-op factors that led to outcomes, specifically mortality. And what it showed was that there was a clear relationship between the level of pre-op anemia, so how far they were on that left side of the graph, right, and the risk of mortality and how high within 90 days after non-cardiac surgery. The blue graph was for men, the red graph is for women. And again, we just see this clear relationship that the more anemic they are going into surgery, the less likely they are to survive going into the OR. So after you have your single-centered large review, there was now a multi-centered review. It completed and it confirmed, that previous study. So this is 2011. This is using the National Surgical Quality Improvement Data Set. It had over 200,000 cases in there. And what we learned is that surgical patients who died were 1.4 times more likely to have been anemic. And patients who had post-op complications were 1.4 times also more likely to have had been anemia. I even point out here that they define mild anemia as a hematocrit of 36 to 39%. And honestly, in my hospital, that's considered normal, right? So we had our retrospective reviews. What about our prospective studies? So this is a European study. It was done across 28 different nations in Europe. It had over 30,000 patients looking at perioperative care and survival. Of note, about 28% of patients had some level of anemia going into the operating room. US numbers, depending on what type of surgeries the patient populations, can be up sometimes between 40 and 60% of our patients have some anemia going into. And again, this dose-dependent relationship with anemia and mortality. If you're anemic, you're more likely to have a longer length of stay. If you're anemic, you're more likely to be admitted to the ICU. If you're anemic, you're more likely to be treated both invasive and invasive ventilation, more likely to end up with central lines, vasopressors, and stuff. Patients aren't doing well. And then 2015, we get our meta-analysis of multiple studies that are looking at pre-op anemia and surgical outcomes. And we get our beautiful forest plot that basically, if you're not anemic, so you're on the right side, you're more likely to do better in surgery, both for non-cardiac surgery on top and for cardiac surgery on the bottom. I'll be honest with you, cardiac surgery has just taken off and has much clearer definitions of what to be doing compared to general surgery after these type of statements. Great. Anemic is bad. If I bring my patient to the OR with a low hemoglobin, they're not going to do very well. So our surgical colleagues go back again, National Surgical Quality Index, right? And they say in this 2017 paper, what happens if we give them a transfusion and we make the number better, right? We always are aiming for that higher hemoglobin. If I transfuse them, will they do better? Turns out, no. Actually, it increases their mortality. So when you break down, even by the level of anemia, patients who are transfused, which are the red bars, versus not transfused, which are the black bars, the rates of mortality were higher almost across the board in the transfused patients. So I made the number look better, but I did not make the patient better. So something to keep in mind. We should not be treating numbers. We should be treating the patients in front of us. So is it just pre-op anemia? No, it's actually lots of different areas where anemia is affecting us, right? So anemia in hospitalized patients, more than 1/3 of patients who are not anemic when they enter the hospital leave the hospital anemic. So we're really good at causing iatrogenic harm. And even mild anemia is independently associated with increased mortality and length of stay. And again, when we give transfusions, so these bottom red bars, it makes the patients actually worse, not better, when you case control them. It's significant relationships with overall poor outcomes in the hospital the more anemic patients get. What's challenging is when you're trying to diagnose anemia in hospitalized patients, the labs that we're taught about using on the outpatient side, like, oh, you're going to look for like a low ferritin or things like that, those actually don't work great in our hospitalized patients because they have these higher inflammatory processes happening. And so there's a whole other process happening in our hospitalized patients or patients with chronic illness with anemia. So before I was mentioning that these patients who were getting transfused, when they made the number look better, they weren't doing better. Why is that? Now, when we all learned about blood transfusions in medical school or PA school or nursing school, we all can like list off the rates of, the rare chance of getting HIV or hepatitis C or things like that. But how many people can tell me the rate of trolley or taco or iron overload? Or what's the risk of clotting of heart attack and stroke after receiving a blood transfusion? What's the rate of increasing your risk of metastatic disease in a cancer patient? These are all very well-known risk factors, but these are not what we're talking about, and this is not what we're teaching our residents and medical students and fellows and our new attendings, especially when they're getting consent. So I actually think this is a great slide because it helps you kind of understand where the risks. So like when we get consent for blood, my guess is a lot of people talk about the risks on the left side. Very low risk of HIV and hepatitis C and things like that. But how many people are saying, oh, by the way, there's a 1 in 100 chance or 1% chance that I'm going to put you into cardiac overload or that you're going to have a allergic reaction or 1 in 10,000 chance of trolley, which actually most people think is underdiagnosed or things like that. So we're probably not doing a great job of actually getting informed consent from our patients. You'll see me mention a bunch of times during this talk a lot of data coming out of Western Australia. In Western Australia, it's actually illegal to sell blood to the hospitals versus in America, that's actually the standard of care. People donate and then the blood to organizations, and then the blood is then sold to hospitals for use. Australia is opposite. In Australia, the Australian Red Cross went to the government. They're like, we just can't keep giving you blood nonstop all the time. Like, you guys got to get control out of your use. And so they actually made patient blood management the law there in Western Australia. But with that, they decided they're going to collect a huge amount of data. And so they even looked at things like, what happens if people just get just 1 unit of blood, right? So this was, again, looking at 4 hospitals, tertiary care hospitals over 6 years, and they over 80,000 patients, and 3% of them just got 1 unit of blood. And just that 1 unit of blood during that hospitalization made them almost 4 times more likely to get a hospital-acquired infection because we know that blood transfusions cause immunomodulation. They were 1.5 more times more likely to have a longer hospital stay, and they were 1.4 more likely to get readmitted to the hospital. So what's going on with these transfusions, right? So with these hospital-acquired infections, so these patients, we know that when you get a blood transfusion, it's like getting an organ transplant. It's going to affect your immune system and suppress it. It's actually interesting, like when old school, when they used to do kidney transplants, they would actually give the patients blood transfusions because it reduced the risk of rejection of the organ because we know it was an immunosuppressant. And so what happens though with that is your risk of hospital-acquired infections really goes up. Honestly, the number of NNT to prevent one serious hospital-acquired infection, you just had to prevent 20 transfusions from happening. When you hear that number of NNT, how many people have to take daily aspirin to prevent a heart attack? It's close to 80. So it's actually this is a very low-lying fruit that you could do to help prevent hospital-acquired infections. I touched upon transfusion and cancer survival. So you tons and tons of other papers. Also, I pulled this one out for colorectal because I recently gave a talk to some of our GI oncologists. So this was a meta-analysis looking at close to 21,000 patients. It was an average follow-up of almost 6 years. And they actually did a great job of following up with a very significant number of these patients. And they looked at transfused versus non-transfused. Patients were more likely to have died in the 59 months who received transfusions. And they were more likely to have metastatic disease and much, much more likely to have had a post-op infection. So when we get a consent for a blood transfusion, a patient who's in their, perioperative state for their oncologic surgery, are we telling them that they might increase the risk for metastatic disease? I know personally, I think I might be a lot more hesitant to accept a blood transfusion if you're telling me that might increase my risk for metastatic disease. Do transfusions really help, right? If you look at almost every transfusion recommendations, it's always in the actively bleeding patient. That's where the data really is, that it supports the strong outcomes that's when blood saves lives or things like that. Other than actively bleeding, we don't have really strong data that blood transfusions really improve outcomes. This is a really brilliant study looking at ICU patients in the US. It was published in 2022. They took 3 ICU cohorts of data, probably over 180,000 patients. It was about 20% of ICU admissions in the US for that time period are covered in this one study. And they brilliantly decided we're going to compare patients with a hemoglobin of 6.9 to 7.1. Now, I think we could all probably agree that there's probably not much clinical difference between a patient with a hemoglobin of 6.9 versus 7.1. And you're right, there really wasn't a big difference in clinically when you looked at their Apache scores, their SOFA scores, all the different critical care ratings that we use. There was one major difference. If they were at a hemoglobin of 6.9, they're almost 20 times more likely to receive a unit of blood. Did they do better, the patients who got a unit of blood? No. There was actually a trend toward patients who got transfused to have worse pulmonary outcomes. So in the end, though, there really wasn't a difference. That 1 unit of blood didn't make a difference. What about GI hemorrhages, right? So that's a big one, actively bleeding even still. And this has been a real change. If you speak to most GI doctors in the past 10 years, there's been more and more literature where even with the patients who are bleeding, we don't want to aim for higher hemoglobin levels like hemoglobin 8 or things like that, because these patients actually are more likely to rebleed when we were giving them blood, because we think, that we were actually diluting their coagulopathy, coagulation status, and things like that. So what we're talking about has been changing over time. So I spoke a lot about transfusions, a little bit about anemia and things like that. The goal of patient blood management is actually not reducing blood transfusions or restricting the use of transfusions or any other therapy per se, but rather moving away from that fact that transfusion is this default decision, right? That's based on a specified hemoglobin concentration. We just have to give a unit of blood. Instead, patient blood management is focusing on patient's blood health, right? That the patient's blood is a valuable resource. And that long before transfusions even considered, there's probably a lot of things that we can do to improve the health of this patient to get to that point, to even prevent or get that they never even get to that point where we're talking about transfusions. We've let the patient go too far, too sick at that point. So there are 4 main key concepts in patient blood management: managing anemia, blood conservation, optimizing coagulation, and patient-centered decision-making. Why do you guys care about this? Because the World Health Organization put out a call in the end of 2022, basically saying that there's an urgent need to start implementing patient blood management protocols around the world. And what does the WHO do? They alert health ministries health departments, policymakers, and encourage them to start getting things to start changing in their countries. So guess what? A few weeks ago, the implementation guide came out with recommendations for how countries should start implementing these patient blood management programs to overall improve global blood health. Like we hear about heart health and brain health, greater women's health. So blood health is probably a newer term that you might be hearing more and more about. There are over 3 billion individuals in this earth who are affected by iron deficiency, anemia, blood loss, or coagulopathy. So it's a huge issue facing the world population. I'm going to be honest, America's way behind the rest of the world here at this point, especially in countries where, again, blood can't be sold. And so here's an interesting article summarizing strength of patient blood management programs in different countries. The ones I highlight in green have a very strong both top down and bottom up programs. If you're interested in data, Western Australia for clinical data, if you're interested in more of the financial aspects or trying to sell this to the higher ups in institutions, Switzerland, great data coming out about the costs of them. Your patients are talking about this. Also, this is being in the New York Times, the New Yorker. I think there was Women's Health, like anemia, iron deficiency. It's out there in publications and people are bringing it to their patients, to their physicians as well. This was a quote from Dr. Amy Wyand. I see a lot of adolescents who have heavy menstrual bleeding and about having severe anemia where they actually have to be admitted to the hospital. And oftentimes these patients haven't even recognized that their bleeding was abnormal. It's all too often I meet patients along the way who were told, you just live at hemoglobin of 10, that's where you are. That's your normal. No, that's not normal. It's not normal to soak through multiple pads and things like that. It's not normal. We still have a lot of work to do there. Choosing Wisely campaign. This is a part of the American Board of Internal Medicine. They ask major societies to come up with 5 recommendations of care that is either overused or inappropriately used. So the American Association of Blood Bankers, the people who make their money giving out blood, right? They put out recommendations and saying that don't give too much blood, right? Don't transfuse more than what's necessary. Don't treat iron deficiency with red blood cells. Other things like not, reversing warfarin anymore with FFP, and don't perform serial blood counts on clinically stable patients. So I mentioned to you the Western Australia data, right? And this aggressive call for patient blood management programs, it's based on these large studies. So Western Australia, with their data, they looked at 3 years before and 3 years afterwards, and they had about 6,000 patients in this paper. Looking at their pre and post implementation. And as you can see, they had a significant reduction in mortality, length of stay, nosocomial infections, thrombotic events, including stroke and heart attack, all these things that we know are linked to blood transfusions. And they did this all while their case mix index increased, meaning they had sicker patients over the years. Oh, and on top of that, they saved the hospital a ton of money, right? So I think if you walk into your CEO's office, you're like, I know how to save money for you and improve outcomes, they're going to want to listen to you. Great. So Western Australia does it. They're an island onto themselves, right? What about this? What about other nations that may be a little closer to how we practice? So looking at Europe, this was looking at 17 studies, combining over 230,000 surgical patients and comparing patients in institutions that had patient blood management programs versus ones that did not. And again, very similar outcomes to what we see in Western Australia, that transfusion rates decrease, patients stay in the hospital less time, they have less number of complications, and they're less likely to die. So when people see me in the hospital, they're like, oh, bloodless. And I'm like, no, don't think about bloodless. Don't think of Jehovah's Witnesses. I want you to think about patient blood management that is really just for everybody. This isn't just for the patients for whom blood transfusion is not an option, especially because anemia is very common. Patients who are anemic have worse outcomes. And we know that transfusion adds a risk to these patients. Okay, so taking all this information about all the bad things I talked about, how do you actually practice this type of medicine? What are the components of it? So we'll kind of walk through all 4 of them. Anemia. So first of all, you have to actually identify the patients who are anemic. So when you send off labs and the patient comes back at a hemoglobin of 10.9 or 11.3, that's not normal. We have to treat that. That patient needs to be worked up. Specifically for the operating room, we stress about that we need time to get these patients optimized, so they need to get their labs done. Actually, I'm very lucky to work in an institution where it's actually hospital policy that for any major surgery that the surgeon has to identify the patient's anemia and to get them started to get treated before they go to the operating room. And so if that doesn't happen, I can't go to the OR, the surgeon can't go to the OR. This is a hospital policy. We all signed on to this. And it's actually seen as a patient safety failure if it does go through and it goes to QI review committees and things like that. And so it's not a battle between two people. This is the hospital policy because this is what we need to do to have good outcomes for our patients. I keep mentioning anemia is really common. I'm sure that anyone on this listening to this talk has seen one of these patients today, probably. Maybe not if you do pediatrics, but rheumatoid arthritis, inflammatory bowel disease, chronic heart failure, kidney disease. These patients are all extremely likely to have anemia. Why are they extremely likely to have anemia? So back to second year med school, right? How do we do iron regulation? So normally your iron levels drop. When your iron levels drop in your blood, your hepcidin levels drop. When your hepcidin levels drop, that allows you to absorb iron through your GI system and release any stores of iron from your reticuloendothelial system. And once those iron levels increase, then the hepcidin levels go up and you stop absorbing iron and you stop releasing iron. Great. What happens in my patients who have any inflammatory process or any chronic disease? They have upregulation of hepcidin. And now hepcidin levels are just high. It doesn't matter what iron levels are. My hepcidin levels are staying high. And my hepcidin levels are staying high. I can't absorb any iron from my gut. And I can't release any stores that I have. So if I can't absorb and I can't access my own internal stores, how am I going to get iron to my bone marrow? So we actually do have IV iron. Now, traditionally, people used to be extremely scared of IV iron because they were some horrible anaphylactic reactions. But in the last 15, 20 years, there have been some really great changes and new formulations of IV iron, which have really low allergic reaction rates, and they're much better tolerated. And so I think we also have to get rid of that fear part of it and, culturally what's happening. Also, we've learned that the way we give oral iron has to change as well. We know that when you take oral iron, you have a small increase in your iron levels, and so you get a rise in your hepcidin levels. So next day, when you take that iron again, or later that evening when you try to take iron again, none of that iron is being absorbed through your GI tract because your hepcidin levels are high. All you're getting are the GI side effects. So actually look at new recommendations are that oral iron should be taken every other day. There is a newer form of oral iron that doesn't have that recommendation, but I think that also the dosing of how we give people oral iron is also changing. IV iron, they cost less than erythropoietin stimulating agents, which I'll talk about shortly, but a lot of times you need them together. They're usually very well tolerated, and it works much faster than those oral forms, especially in patients we need to get them up faster, right? So I think like second and third trimester for OB, that's where your IV iron comes in. And best part, it works even in inflammatory states. It's safe in pregnancy as well. So these are some of the trials, again, not huge trials, but showing safety for the different forms of comparing IV iron and oral iron. And basically they almost always favor IV iron in pregnant women, especially when you have less time to get the patient to be iron replete, or the patient has failed oral iron, that they've been on it for multiple weeks and it's not working anymore. I told you that there's a new form out there. Sorry, I just realized that the slide doesn't look so pretty. Sucrosomial iron. It's an iron with a special shell around it that it's absorbed very differently. So it's hepcidin independent absorption, and it's over the counter. Actually, it's much cheaper than IV iron as well, and for the hospital it requires much less nursing care and things like that. It's really interesting. This is a small Italian company, and they have been putting out these studies where they put themselves up an oral drug against IV iron, and showing over and over again that it's equivalent. They're small studies, but it's pretty impressive that they've been able to do it. Cancer, IBD, heart failure. It's an interesting, I think it's something to watch. And this sucrosomial shell, they're going to be putting other medications into this new shell. So I think this is going to be a form of giving medications that is something that we should watch for. People ask me, how much iron should I give? We actually have a formula to determine how to do that. It's called the Ganzoni formula. As more literature comes out about the appropriate way to replete people, what we've learned is the Ganzoni formula is a really great way to start, but you might need more. It might underdose as well. One thing I would remind my residents, when you're calculating how much iron to give, remember that a unit of blood has iron in it as well. And there is a risk of iron overload if you give too much. So what happens? Like, I need to treat this patient. I need to get them ready to the operating room or ready for delivery or things like that. How long is this going to take? So Nicole Gwynn and her team at Duke were phenomenal in their timing when I was just starting to do these concepts of these papers. And they came out with this paper where they compared patients who went through their pre-op anemia clinic and those who didn't for patients going under orthopedic and gynecologic surgery. And what they showed is that patients who went through their pre-op clinic and got IV iron and ESAs were much less likely to get transfused. And it wasn't powered to detect this, but like less length of stay, ICU admission, less readmissions. But they were able to show with their very not such an aggressive pre-op anemia protocols that they had about 0.04 grams per day, a deciliter per day of increase in hemoglobin. So you could actually like trend out how long is this going to take to get a patient to a normal hemoglobin. So I mentioned there, we also might need erythropoietin stimulating agents as well. So just a quick reminder again, erythropoiesis is how we form new blood cells. It starts in our bone marrow. Erythropoietin is the main regulator behind erythropoiesis. But the problem is again, that chronic inflammation strikes again, right? Or even any inflammation or even some medications where we either have less EPO being made by our kidneys or we are much more insensitive to the erythropoietin that we have. And sometimes we have to like kickstart and push it higher. You could actually calculate and see how appropriate a patient's bone marrow is responding by calculating something called the reticulate index. MD-Calc has those calculators to help you figure that out. So what happens if I say, okay, the patient's bone marrow is hypoproliferative, they need an erythropoietin stimulating agent? We use these. Our renal colleagues have done an amazing job, a lot of great research and studies, and telling us how to improve dosing and indications and things like that. There is no standard dosing of what to use, especially with these patients with chronic anemia, not related to kidney disease, but like to, HIV or from chemotherapy or things like that, or critical illness. So that's where the dosing is not as standard. For us, there's always a risk and benefit discussion about thrombotic risk, but remember, blood transfusions are also increased risk of thrombosis as well. There are the clinical indications for the use of ESAs that the FDA does approve for. So your CKD a lot of times falls off. People always remember the end-stage renal disease patients, but they forget about those stage 3 CKD patients who also are approved for ESAs, your cancer patients, preoperative HIV, and also critical illness. Unfortunately, some like studies in critical illness show like less than 6% of patients who meet the criteria for ESA in the ICU actually get it. I thought this was interesting. It was 2 different studies, and the red arrows point to the same time period. So here was the use of ESAs, and here is the consumption of packed RBCs in America. Now, again, trick trial, things like that coming out, but you could see ESA seem to really help us reduce the amounts of blood cells that we are using in the US. So second part, blood conservation, keeping patients' blood in their body. So for my day-to-day, that means I need to work with excellent surgeons. We need to have like access to all the appropriate hemostatic devices and techniques. We have to have excellent communication. And there are actually some things that we could do in the operating room as well to help keep patients' blood in their body. The 2 ones I'll talk about today are acute normovolemic hemodilution and intraoperative cell savers. So this is a cool one that I get to do. It's called ANH. And we use this in big surgeries. What happens is, let's say I have, I'm doing a Whipple, right? And I know there's vascular involvement and this might get a bit bloody. When I come into the operating room, I'll take off 2 to 3 units of blood from this patient and I will dilute them down. So now any shed blood that the patient loses during the surgery is actually dilute blood. If I have any coagulation or any other issues, I have this patient's own blood to give back to them if there are any issues. And at the end, I could just give them a little bit of Lasix, or we could diurese them to get off the extra fluid if they don't need it. And this is a really nice way to help prevent unnecessary transfusions. And so we use this routinely in all of our open heart, large liver cases, and it's a really nice technique. The only problem is I need my patient to have a normal starting hemoglobin in order to do this. I can't start them anemic and take off blood because then they won't tolerate it. So this is one of the big reasons why we really do push for our patients to come optimized to the operating room, because if we don't have that, then I lose tools in my tool chest to appropriately treat the patient. This is kind of what it looks like. We literally we use an A line or a large bore central line, and we take blood out and we leave it in the storage bags, and we have rockers to help prevent clotting over time. Second part, cell saver. So this is where we all the blood, like blood that's suctioned from the surgical field or any process is taken into a machine. So right here on the right bottom, this is the teeny tiny little cell savers we have in our hospital, where the blood is then washed and then filtered and spun down, and we can return it. This is we're one of the rare institutions we train all of our anesthesiologists and CRNAs to run these machines. So we don't need to wait for another company to come in or things like that. There's even a cool company that they create sterile canisters. So let's say you don't have the machine in your room and there's unexpected bleeding. I could quickly just take my surgical suction and hook it up to this sterile canister until I can bring in my machine and set it up. So for less than $50, I could probably save a few units of blood for that patient. People always say, "Oh, but you can't use this in like contaminated cases, right? Like if they're like doing bowel surgery or cancer surgery, or what about amniotic fluid?" And there's multiple studies that show that that's not true. There are ways to appropriately use cell salvage in these studies and help prevent needs for further transfusions. Unfortunately, one of the ways that we don't keep patients' blood in their body is by phlebotomy. Every year, we're taking about 25 million liters of patients' blood and throwing it into the garbage can. We know there's a clear link between the amount of blood we take and level of anemia, and we're really bad at recognizing that we're causing this anemia. So my amazing colleague Matt Warner out at Mayo Clinic, he recently looked at phlebotomy at his hospital, looking at all the ICUs there. And all the adult ICUs, and they basically included all central venous arterial blood collections. And not surprisingly, phlebotomy still remains a major source of blood loss in hospitalized patient, and the location with the highest phlebotomy rates were the ICUs throughout the hospital. What was interesting, and even in an institution that really has a very strong patient blood management program, about 10% of the blood that they were taking out from the patient was literally just going straight in the garbage, right? Where they were like wasting a few cc's before they sent labs. Even though most hospitals in America all have closed loop systems that we should not be wasting blood, but like literally 10% was just going to the garbage. Median in the ICU was about 5 labs per day and about 41 per hospitalization. Patients were losing about 30 mLs per day and about over 230 mLs in a length of stay. Remember, a healthy functioning adult bone marrow produces only 20 mLs of blood per day. So we were not doing it right. We're just setting them up for failure if we're taking 30, and they don't have a healthy functioning adult bone marrow, most likely, if they're in the ICU. I thought this was a great visual way of seeing it, how much blood we were taking specifically in the ICUs, right? So if you're taking 25 mLs a day in a 15-bed ICU, that's over 11 liters a month. That's equivalent to 45 units of blood. And in a year, that's about 27 adult blood volumes. Not so often. I still like to put this slide up, even though this paper is a little older. Helene Koch and her colleagues were writing about contemporary bloodletting in cardiac surgical care. And their conclusions were, we were astonished by the extent of bloodletting, with the total phlebotomy volume approaching equivalents of 1 to 2 red blood cells per unit in their cardiac patients. So we need to dump that habit of daily labs. Again, back to choosing wisely, Society of Hospital Medicine has shown that it does not help. After you have 3 days of stable labs without much changes in them, there's very little value in getting daily labs on those patients unless there's a clinical change. And so something that we continually work on in our hospital is to move away from daily labs. Third pillar, optimizing coagulation. So a lot of times that's referring to stopping antiplatelets, anticoagulates at the appropriate time. Using real-time labs to figure out why a patient's bleeding and what's actually happening. So viscoelastic testing, having the appropriate reversal agents, and also antifibrinolytics because it's probably way underused. So reversal agents, there are multiple out there for our DOACs. We have protamine for heparin or low molecular weight. We have vitamin K and 4-factor PCC for warfarin. We do not use FFP anymore to reverse warfarin. You should just know this is where the off-label part is. Medications like Andexxa is very expensive, up to $30,000-$40,000 for a full dose for some patients. There's been off-label more than a decade of data of using 4-factor PCC off-label to reverse these medications at a much lower cost of, between $4,000 to $6,000. So we have our own policies and dosing regimens in our institution. Viscoelastic testing. So we're all used to like the PT, PTT testing for coagulopathy. Again, doesn't really necessarily give you a really good idea of why the blood is clotting, not clotting, what's happening. We all try to remember our intrinsic and extrinsic, but there are better tests out there, and we need to start to learn how to use them. So there are three, I'm going to call them competitors. You can't compare them. They're different tests, but they're three main players. There's TEG, and what that is actually a machine that measures the property of clot in whole blood. So there's like a pin suspended in a cup, and the cup turns, or actually the pin turns, and as the blood clots, the pin gets harder and harder for it to turn, and you get this graph of what's happening with the clot formation. And from that, you can interpret things about platelets, plasma, fibrinogen, and lysis. Rotem took instead of rotating the cup, they rotated, instead of rotating the pin, they rotated the cup, and similar concepts as well. Quantra is the new kid on the block, and they're using sonography to put ultrasound through a small device as the blood clots there and see how the ultrasound changes. There is no comparison between results of one to the other. There's no gold standard that has been set. Traditionally, these are machines that were used in open heart and liver transplant. There is a huge push to start to use them in ER and ICU because there are more and more studies that are coming out that these might have a link to reduction in mortality, overall less blood product, less renal injury. And there's no difference in patients needing to go back to the OR or massive transfusion rates. And overall, even while the test is expensive, it ends up helping to save money on the other end. They're not easy to interpret, right? We're all used to just having numbers and having number cutoffs. They are graphs. And like, when do you bring up graphs? You need to open up a separate viewer. So this was something we did to really help give a support guide to our clinicians here of what happens when they do order TEG. Also, because it could be 6 months in between people ordering TEGs if they're not dealing with a bleeding patient very often. And so this is something I did. And then what we're working on now is what the role of AI. This is now an app, and it's actually embedded into Epic for us. And we're trying can we teach AI to interpret the graphs and then help you figure out what your recommendations are while your patient's actually bleeding. So that's some of my interests that I'm working on. Antifibrinolytics. So these are medications. They are not prothrombotic. Once there is a clot, it helps keep the clot firm. They're still underused despite excellent trials. Postpartum hemorrhage, the woman trial, so anything in green here is where there's strong evidence. By the way, if you ever want to read a really fun paper, this was done by a resident and a medical student. It's an illustrated review of TXA, and it's all cartoons, the whole paper. Great job. I love it just because I feel like they need props for just having the guts to submit something like this to a journal. Crash trials, so the use of TXA in trauma, also cardiac surgery, brain injury. That's one of the newer ones. Unfortunately, there were a bunch of recent negative studies in prophylaxis for obstetrical hemorrhage for both C-section and vaginal deliveries. And there was a negative study for the halted trial for GI hemorrhage. So that was a little sad also, but there are rules for it. And the thrombotic risks are not there. There's been very large studies and a lot of statements made now, like people, oh, should I give it if they're at risk for clotting? And there's no relationship between giving antifibrinolytics and clotting. Last part of it is patient-centered decision making. And this is where like I talk about like moving away from these like transfusion triggers or things like that and looking at the patient in front of them. Each patient has their own threshold, right? So a patient who lives at hemoglobin of 9 or 8, because no one's been treating them, and they carry at 6.8, they're not going to be as sick as the person who starts with a hemoglobin of 14 and is now at 8. Right? That patient who went from 14 to 8 might have much more likely have signs of end organ hypoxia or dysoxia as well. One of the big things we do especially for our bloodless patients for blood transfusions not an option, is we help patients tolerate their anemia while we treat their bone marrow issues or their iron deficiencies and things like that. In our bloodless patients, we're minding for these signs of end organ hypoxia or dysoxia as they're becoming more and more, if they're severely anemic. What does that look like? It looks like we're looking for their signs of mental status changes, fatigue, they can't concentrate, their tachycardic EKG changes, they're breathing a little faster, their urine output drops. By the way, none of these included a lab draw to look at a hemoglobin. These were all clinical exam things. We're very aggressive in giving our patients IV iron, with bone stimulating agents. There are not restrictions in our hospital on who can order those. Then people say, I was taught that if we don't give blood transfusions, the patient's going to die. It's not true. I could show you ours is older papers from our critical care literature that we have similar outcomes for our bloodless and our non-bloodless patients. This is a more recent paper, Steve Frank at Hopkins. They did 4-year retrospective review. They had 1,100 bloodless inpatients. You'll see in a few minutes why I laugh at that number because that's very low for us compared to 137,000 non-bloodless patients at Hopkins. And guess what? Their length of stay and mortality were actually the same. Not surprisingly, well, even more surprising, the bloodless patients were less likely to get hospital-acquired infections, and they cost the hospital less money overall, both the surgical and non-surgical patients. So I bet you, again, if you walked into a CEO's office of a hospital and you're like, I know how to save you 8% on your total hospital cost, they're going to be interested in hearing what you want to say. So what does the bloodless medicine program look like at Inglewood? It's an educational process to enroll in our program. So we have full-time coordinators who do an educational process, enrollment in one-to-one in the appropriate language and appropriate educational level. This is a huge time saver for our clinicians because this is not a simple, straightforward process. We go through all the different fractions of blood. In order to be part of our bloodless program, you have to be someone who doesn't accept whole blood, red cells, white cells, platelets, or plasma. Things like albumin, cryo, fibrinogen concentrate, PCC, prothrombin complex, those things are considered matters of conscience, and or using your own blood, such as cell saver blood or acute normovolemic hemodilution. Those are the things that we need to educate and speak to them about. It's really from a top-down, bottom-up process from the moment they get registered. They're asked if they're part of this program to there's funding like for people like in my position, every nursing orientation includes education about this. There are signs everywhere. It's everyone who works in our institution is very aware of this program. You'll see why. This is a huge number of patients for us. So you remember that Steve Frank, 1,100 over 4 years of all their Hopkins studies over, institutions, that's 2 years for us in our 250 bed hospital. So this is routinely a group of patients that we treat on a regular basis. So 2024, we had 38,000 outpatient procedures or appointments for our bloodless patients, and 80% of them are traveling from outside our catchment area to come to their care for us. We have very significant support and protocols of how to treat these patients, specifically when they're very anemic. There's always this risk and benefit between treatment compared to the complications of anemia. People are always like, well, what should I do when I have a bloodless patient and they're bleeding? So stop the bleeding. I can't tell you, get these phone calls from other institutions. They're like, they're having a GI bleed. I said, so did you scope them? Well, but they're anemic. Okay, well, they're going to get worse. They're going to get, more anemic unless you do something. So getting the appropriate services in, GI, addressing the coagulopathy, making sure they're getting the appropriate reversal agents, replacing any factors of efficiency, and then you doing things like anemia tolerance, making sure that they have increased oxygen content, reducing their oxygen consumption, even if that means intubating, sedating, and paralyzing patients. This is a screenshot of what my app looks like. It looks even nice and epic. It's kind of cool. I hope this was an interesting overview of what we do. One of the nice things that my institution does is we realize that there are many hospitals that don't get exposed to this on a regular basis. And we offer our services to help walk you through what we have learned from years of experience. And it's actually available 24/7. So you just call the hospital, ask for bloodless, highly likely to end up talking to me. I do not do this alone. I had some amazing mentors and leaders. Dr. Arya Shander, who was the medical founder of this program and one of the smartest men I've ever met. Sherry Ozawa, her background, and she's a nurse, but she's a forward-thinking person. She was actually one of the 10 people who helped write the WHO guidelines. Dr. Lobel is the head of the anesthesia department. And even though we are a private practice group, he still realizes that involvement in outside the community, things like this, and giving talks to JOMA is something that he wants from members of his group. And Dr. Cohen, who's the chief medical officer of our institution. My fellow ICU doctors who handle a lot of the phone calls from other institutions day and night when people need help. The amazing anesthesiologists and CRNAs. If you look at almost all the literature in patient blood management, it came out of our department, the original studies of what we were doing. And remember, private practice people out there publishing is not the norm. And then my amazing bloodless program people that I work with. That's where we're at. And then again, Shula asked me to put this slide up there for those people who want their CME credit.
Wow. Thank you so, so much, Dr. Kaufman. That was an outstanding and very eye-opening talk. I think certainly as an incoming resident, this is not a subject that a lot of us have had a lot of exposure to, if any at all. So really, thank you so much taking the time tonight. If anyone has questions, feel free to pop them in the chat or to chime in. I think the biggest one that I've left off is, what are we all waiting for? Why have we not all implemented this already? Which it sounds like there has been decades of work on your part, but I hope this is something that we'll continue to see more of throughout
So that's
my own
always
training.
so it's actually a really quick question. Like, right, people are like, well, why isn't everyone doing this? So there actually is literature about how long it takes for things to trickle down through the literature into practice. And it's sad, but it's about 20 years to get to full compliance and stuff. And usually there has to be not only just a carrot, but there has to be a stick as well. And so that's why I kind of stress the WHO aspect, because Medicare, they're coming out with their new, every few years they come out with different quality index things that they tie to your, payments. Blood transfusion and patient blood management is one of them that's coming down the road. We're writing them right now for them. So it's coming down the road. So you're going to have to learn it no matter what. And culture change is not easy. Listen, I mentioned to you before we started that in the US that blood is sold. So there's a huge financial incentive, some very large organizations that their day-to-day operations are greatly affected when the use of blood products goes down in the United States. They don't like people like me. It's always fun when I actually go and speak at like the blood banking talks. So
Gotcha.
it's fun. It's nice. Everyone behaves, but they're always like,
Definitely, yeah. It's challenging from both ends. I guess a technical question is, it might be another talk of its own, but I'm curious if you could speak to a little bit more about how you manage, blood loss in a bloodless patient in an acute setting. Obviously, prevention is always ideal, but what are some of those strategies? Let's say you have a patient that is actively bleeding. What are some of the strategies that you
So
employ?
really like getting in early. So when I pick up the phone and I call my IR doctor or my GI doctor and I say, I have a bloodless patient and they're bleeding, they mobilize their team and they come in. So like that may be like for a colonoscopy. Usually we wouldn't do an emergent colonoscopy in an unprepped patient, right? But maybe in this patient, we are going to have that discussion about putting them the increased risk because we can't do that, or we're going to get our IR team emergently coming in. So a lot of times it's that quick reaction and not sitting and not waiting and not, is it really bleeding, not bleeding? I don't know. Let me take another hemoglobin, let me trend. It's not like that. Capturing their blood, especially if they're willing to let us cycle, clean it, filter it, and give it back to them. So maybe things like traditionally like chest tube output, where we don't normally do that, post surgeries or things like that. I will do that. We actually have special chest tubes meant to do that. So I'm going to use those type of things with my bloodless patients. I think the biggest thing is like believing what's in front of you. If they're bleeding, they're bleeding. It's not like, oh, I'm not sure. And not waiting. And that's the biggest part that we see, is that when people wait. In the operating room, it's rare that the blood's going everywhere. We usually can contain it and capture it. So that's at least nice. That what happens is they become coagulopathic, because at some point they consume their other factors, and that's what they don't have. But many of the patients will now with factor, with like fibrinogen concentrate and 4-factor PCC, they're much more, we have other options now to do that. We'll see, like maybe platelet concentrates are coming down the road at some point as well.
So those blood products are still considered within the scope of your sort of toolbox for treating bloodless patients.
So at Inglewood, we do a lot of work. So those are like fractions. So they don't want cells, but fractions of blood, most of them are willing to accept. Interesting enough, about 95% of our bloodless patients are Jehovah's Witnesses. 5% are not, for other reasons. Vegans. Yeah, not so much in the Northeast, but much larger in other parts of the country. People who don't want blood from COVID vaccinated people is a very big growing thing. And there's multiple states that are dealing with legislation right now that will make the hospitals make non-COVID, non-vaccinated blood available. The problem is that people who donate blood are usually COVID vaccinated.
I've come across patients with those preferences, so it's something I can imagine.
Area. There are some small Native American communities that also don't accept blood. They see it as a source of life and parts of their soul. So that as well is part of it. For what we've learned at Inglewood is for the fractions, because we've created this whole system, they trust us that we're only going to do what they tell us to do. They're much more willing to accept these fractions and techniques. We have one surgeon who operates at 2 different hospitals, and he takes care of a huge amount of bloodless patients in both. And he actually compared both. So 98% of our patients accept all fractions and use of their own blood at Inglewood, versus it was less than 80% at the other hospitals. And that was with him doing the education. So there's a trust in the system as well. And that's what like even just words, like we don't say refuse blood, we say decline blood. Like there's a way that we talk. When we get to the point where someone's severely anemic, I don't come in and tell them they're going to die because actually I don't have literature that's going to tell me that that's true. What I do tell them is this is the point that I would be advising my other patients to take blood if blood transfusion was an option for them. Because you've told me it's not, these are the things I'm going to do. And we have our anemia protocols and things like that. It gives them a chance. They could tell me they changed their mind. It's rare, but it does happen. But that's the aspect. I think there's a culture, there's a sensitivity, there's a level of trust that we've created with these patients. Interesting as a Jewish Orthodox woman, this respect for people who might have beliefs that are different than ours permeates the hospital. That's what's interesting to me. I don't think it was meant like when they designed everything, but that they thought that that would happen, but it's a really beautiful side effect from it.
That's fantastic to hear and to see playing out. And I guess my last question, because I'm still in the floor, is in terms of sort of I've heard it called the vampiring, the iatrogenic anemia from all the blood tests that we put our patients through. Are you aware of any like proposed like formal or guideline changes or changes to blood volume, any like protocol changes on that end?
So there was.
Anything
So
coming
there are
down?
studies looking at, there's the large one was a Stratus trial that was done in Canada actually during COVID. It was and so they looked at low volume blood tubes. So low volume blood tubes, which is what we actually use at Inglewood, are test tubes. They look the same as regular test tubes. They sit in the machines, the carousels that all these hospitals have, but their suction on them is set to draw less blood into them. And so it's almost about half the volume that's taken in. And what they showed in the Stratus trial was that probably on a hospital level, it makes a difference. You're going to end up preventing some blood transfusions. And on a patient level, the patients who are there for long periods of time, 18, 19, 20 days, that's where it's probably going to make a difference. So it's probably more of an institutional level, the amount of blood we're taking rather than on a patient level. I saw on a smaller scale some other ideas about, it was an epic about creating like a temperature gauge almost, but like every time you order blood, you could see how much blood is being taken from the patient and the total that you've removed from your patient every time you order. That might make you think before you hit, sign. You're like, ooh, that's a lot, right? And maybe I shouldn't do that. I saw another great idea. It was started by a residency program. They have a lab holiday order. So let's say like a lot of times my ICU team, we've decided we are not drawing labs tomorrow morning. We don't need them. We don't think there's a clinical need for them unless something changes in the middle of the night. But then like the amazing cardiologist comes by and he loves the res. He goes, oh my God, they forgot to put orders in. I don't want them, Margit to be angry at them. I'll just throw the labs in for them so like they don't get in trouble tomorrow morning. And then tomorrow morning I get there, I'm like, who ordered labs on this patient? We all agreed that we weren't going to order labs. So this Teams, they have a lab holiday order. They type it in, and no one can order labs on that patient for the following day when there's a lab holiday order unless they delete that order. So it's a message to all the clinicians. We're not planning to get labs. If you need labs, you need to call us and we need to discuss this clinically. And it's about changing the culture and the mindset. So small scale, big scale, but the Society of Hospital Medicine says after 3 days of stable labs, you're not gaining any real benefit.
No, it's nice to hear about all the things that are coming down the line for us, and we'll see how that continues to evolve. But really, thank you again for taking the time to educate us all and make us a little more aware of some of the things that we can do, even without a hospital protocol. Any other questions, feel free to pop them in the chat. We can give that another minute or so. And once again, if you are CME eligible, don't forget to either text the code on the screen or scan the QR within the next 24 hours. It'll expire tomorrow night. I'm going to give it one more minute to see if anything comes through. But really, thank you again so much, Dr. Kaufman. This was a really exciting talk to hear about. And JOMA does host regular grand rounds, so do keep an eye out for the upcoming ones. Feel free to reach out to us if you have any particular topics or speakers of interest. We'd love to hear where the interest is and host who we can. So with that, I'm going to wrap up and thank Dr. Kaufman once again for an astonishing talk, some would say. And we look forward to seeing you all at the next one. And have a great evening.
Thank you.
Take care.